amount of sodium going out of the kidneys matches the amount coming in. And here's a flow chart showing you how this works. So when you restrict your sodium intake, you shrink your ECV. This increases the activity of the SNS and RAS systems. This leads to sodium retention and less sodium excretion, and therefore the restricted sodium is matched by decreased excretion, so sodium balance is maintained and in equals out. Conversely, when you consume excess sodium, like going out to a restaurant, your ECV expands, your sympathetic nervous system and RAS systems are dialed down, there's less sodium retention and more sodium excretion, and thus once again, sodium balance is maintained with in equal to out. Let's return to this graph one final time, and once again, let's begin in a state of sodium balance where sodium in equals sodium out. At this point, our ADH level is at baseline, and the activity of our sympathetic nervous system and RAS systems are also at baseline. We then begin consuming excess sodium. This leads to a situation where sodium in is more than sodium out. This raises the plasma osmolality, and because of the higher plasma osmolality, our ADH level goes up. Because ADH goes up, we will begin to retain more free water. That will normalize the plasma sodium level and return the ADH level to baseline. However, the excess water that we have retained has increased our effective circulating volume, so we've moved up along the y-axis. Because of the higher effective circulating volume, the sympathetic nervous system and RAS systems will be dialed down. This will lead to more excretion by the kidneys of sodium, and this will restore sodium balance. So once again, sodium in will equal sodium out because we have dialed down the sympathetic nervous system and RAS systems to make up for the increased sodium consumption. So now we have returned ourselves to water and sodium balance, but in order to do so, we had to increase our ECV and we had to get to a state where our sympathetic nervous system activity is decreased and so is our RAS activity. Now I've wiped away my ink so I can make an important point. You might be inclined to think that the sympathetic nervous system and RAS systems would drive the ECV back down to the level where we started, but that's not the way these systems work. Under physiologic conditions, the SNS and RAS systems are designed to maintain sodium balance, not necessarily to maintain a constant ECV. And at this higher point on the curve shown here, we have achieved sodium balance. In is equal to out. What this means is that the body is going to continue to operate at this higher ECV as long as sodium consumption remains high. If we continue to eat high salt foods day after day after day, we will continue to operate at a high ECV. The only thing that will return us to a lower ECV is if we stop eating high salt foods. If we go back to a lower level of sodium consumption, then our ECV will fall back to the level where it started from. And if you want to prove this to yourself, try eating a bag of potato chips every day for a few days. You will see that your weight will go up and it will stay up. And the reason it's staying up is because you're consuming lots of sodium and therefore your body is operating at a higher ECV. So on this slide, I've summarized some key points. High sodium intake expands the effective circulating volume. Clinically, you can see this as weight gain, and in some patients, this can cause hypertension. A high sodium intake is one of the potential causes of hypertension, and that's because sodium expands the ECV. On the contrary, low sodium intake contracts the ECV, so if you start eating a low sodium diet, you will see your weight go down over the next few days, and eating a low sodium diet is also one of the ways to improve blood pressure in patients with hypertension. I'm going to finish this video by talking about pathologic states where sodium or water are out of balance, and these states are very easy to understand if you understand the principles of sodium and water balance I just went through. First of all, I want to make a general point. When a pathologic state leads to a lack of water balance, this is reflected by abnormalities of the plasma sodium level. So hypo or hypernatremia are problems of water balance, not sodium balance. In contrast, when there's a problem with sodium balance, this leads to alterations in the total body volume or effective circulating volume. So hypo or hypervolemia are states in which there are abnormalities involving sodium intake and output. I'll finish this video with a couple of clinical correlations of sodium and water balance, and the first one is GI losses. So patients who have nausea, vomiting, and diarrhea have GI losses of salt and water. This leads to contraction of the effective circulating volume and activation of the sympathetic nervous system and RAS systems. In addition, the volume loss leads to ADH release. This is that non-osmotic release of ADH. It's driven by volume sensors, not plasma osmolality sensors. So when you are in a state of significant GI losses, you are in a hypovolemic state, and ADH will be released no matter the plasma sodium level. In other words, the ADH level is no longer controlled by the plasma sodium level. This means that water balance control by ADH has now been lost. Free water is going to be always retained by the kidneys because because the ADH level is always high. In this situation, your plasma sodium level is determined by your relative intake and losses, and thus it is very easy to develop hyper or hyponatremia in the setting of GI losses because the ADH release is no longer controlled by the plasma sodium level. What more often happens with GI losses is that patients develop hyponatremia. This is because they're drinking free water because it's easy on their stomach. In addition, they're often not eating, which means they're not consuming any sodium. This just worsens the volume loss and leads to more retention of free water that dilutes the plasma sodium. Hypernatremia can occur in some situations, however, if the patient is not taking enough free water to match the free water losses from their GI tract. Heart failure is another clinical example where sodium and water balance can be lost. Heart failure patients have a chronically decreased effective circulating volume because of low cardiac output. This leads to chronic activation of the sympathetic nervous system and RAS system. Thus, sodium is chronically retained by the kidneys of patients in heart failure. In addition, free water is retained to balance out the sodium that the kidneys are holding on to. This leads to a situation where sodium balance is disrupted. In heart failure patients, sodium excretion is always reduced by the kidneys. Thus, if a heart failure patient consumes a high sodium meal, they will easily get into a situation where intake is greater than excretion and they are out of balance. And as we discussed before, when you have excess sodium, this leads to hypervolemia, which is common in heart failure patients. Another problem that heart failure patients have is that the ECV does not increase normally with fluid retention. So if a person with a normal heart consumes a high sodium meal, their cardiac output and their ECV will go up. However, patients with failing hearts are unable to increase their cardiac output. Therefore, they always have a low ECV even after they consume excess sodium. The result is that they get congestion, which is typical of heart failure patients. They have lots of extra volume in their body, but it's in the wrong places. It's not going into the effective circulation system. Therefore, they develop congestion symptoms like pulmonary edema, elevated jugular venous pressure, and pitting edema. As we discussed before, in heart failure, the ECV is always down, but the total body water goes up for the reasons discussed on this slide and the last two slides. In addition to sodium balance problems, heart failure patients have a water balance problem. The low ECV leads to chronic ADH release. ADH is always high in heart failure patients, and once again, this is driven by the volume sensors, its non-osmotic release of ADH, and therefore the ADH level is no longer controlled by the plasma sodium level. This means that water balance control by ADH is lost and free water is always retained by the kidneys, so the plasma sodium level is determined by the relative intake and losses. And for this reason, hyponatremia is very common in heart failure patients because they often drink more free water than they need, and this leads to hyponatremia. I'll finish this video with this slide on SIADH, which is the syndrome of inappropriate ADH secretion. This syndrome has many causes, and I discuss it in detail in the video on sodium disorders. But what I want to focus on here is the physiology, which is very easy to understand if you understand sodium and water balance. So in SIADH, as the name implies, there is excessive ADH release. This leads to excess water retention and causes hyponatremia. Now, you might think that excess water retention would lead to a rise in the total body water, but it does not. The total body water in patients with SIADH is normal. The reason for this is because the water retention expands the ECV, which leads to a decrease in the activity of the sympathetic nervous system and the RAS systems. This leads to sodium excretion and lowers the ECV back down to the normal level. So the key findings in SIADH are hyponatremia, normal volume status, and a concentrated urine, all the effects of elevated levels of ADH leading to hyponatremia but a normal volume status. And that concludes our video on sodium and water.